guest lecturer today, Dr. Melissa Casino. She's going to be spending the day with us, and we have this great itinerary that includes this morning's discussion, grand rounds at noon, and then at 3 o'clock we'll be having some case presentations, and then throughout the day she's going to be talking with many of you guys about the work that you guys do and the work that she does. It was almost a year ago when one of our cardiac patients, a sweet teenager I had known since early in my career, was admitted to our pediatric ICU after attempting suicide. Within the same week, another patient I had followed for over a decade, a young man who had survived countless surgeries and was described by his sister as the funniest person in the world, had died suddenly, potentially from an overdose of medications associated with his anxiety. These two cases personally hit me hard, but I was not alone in sadness. There were many, many people in our group who were personally touched and were reaching out to each other in a time of grief, asking, what could we have done? Are we doing enough to identify and support these kids psychologically in the same way that we support their heart? I think everyone here understands how complex some of the hearts are that we take care of, but something I think we may not think about nearly enough is that the early and significant medical and surgical care, prolonged hospitalizations, psychological medicalization, activity restrictions, and significant underlying familial anxiety make these children at particularly high risk for significant underlying depression, social isolation, and other significant psychological stress. So what can we and should we do individually, institutionally, and universally to more effectively identify, diagnose, treat, and maybe even dole some of the significant psychological stress that our patients are struggling with on a daily basis? For everything we have done to take care of their hearts, we have so much farther to go taking care of their minds. So I'm incredibly excited to introduce Dr. Melissa Casino. Dr. Casino earned her doctoral degree in clinical psychology from Case Western Reserve University and completed postdoctoral fellowship in pediatric psychology and pediatric palliative care at Boston Children's Hospital before joining the University of Michigan faculty in 2015. Go Blue. Dr. Casino developed and launched the MCOPE Psychosocial Services and Research Program in the Congenital Heart Center at C.S. Mott Children's Hospital in 2020. She directs a research program funded by the NIH, which focuses on healthcare communication, medical decision-making, mental health, and resilience in pediatric critical illness. She's currently serving as PI and study chair of the first federally funded multi-center randomized trial of a mental health and resilience-focused telemedicine intervention in pediatric heart disease. As a psychologist, Dr. Casino is an international leader in the fields of pediatric heart disease, transplantation, and palliative care. She serves in leadership roles for various national and international organizations, and most recently, she was named the program chair for the 2027 International Society for Heart and Lung Transplantation annual scientific meeting in Sydney, Australia, an exceptionally remarkable accomplishment. So please join me in giving a warm welcome to Dr. Melissa Casino.
Thank you, Erin, so much for that really kind introduction and for sharing your why, and I think the why of so many of you for being in the room today in terms of why we're talking about this. And I just want to say, thank you for having me. Thank you for the opportunity to meet with all of you today. This truly, when I talk at Grand Rounds, I'm going to be talking a little bit about purpose in academic medicine, and I'll be sharing the stories of some of my patients. And this is such a gift for me to be able to come and talk about something that brings me so much purpose in my work. Certainly, there are a lot of challenges amidst us in academic medicine and healthcare, and it's the things that really ignite us, the things that we really care about that keeps us coming. So I just want to thank you all, because it really is a gift to be able to share the things that I'm most passionate about. So this morning's talk is, I hope, going to be really focused on some kind of practical ideas for you as cardiology clinicians in terms of, building mental health supports here in your heart center and bringing some of these supports to your patients and families, both with large vision, so thinking about, at the program level and growing resources, but also without a ton of resources. What can we do within our clinics? What can we do to really help our patients when we don't have a whole team of psychologists to refer them to, or our social workers are covering, 6 other clinics at the same time? So I have a bit of content, but I certainly also, being among my people, I always joke that I'm a part-time cardiologist myself. So that we can also have some question and discussion today and thinking about how to move this forward here in your own cardiology group. All right. All right. So first things first, I think it's really important to set the stage. You know, in 2021, the first ever national emergency in youth mental health was declared. Certainly, this was coming out of the pandemic and the impacts of the pandemic on young children. We had already seen increasing rates of anxiety and depression in adolescents prior to the pandemic, and the pandemic really led to a worsening of mental health in children, not only here in the United States, but throughout the world. There was 100% doubling in youth depression and anxiety, and over 50% increase in adolescent girl suicide attempts in the United States in 2021. So this was a really big deal, with the first time ever that a number of organizations came together and said, we really need to do more about mental health for our young people. And I think, as Erin was mentioning, you know, the young people that we take care of, they not only are facing kind of all of these same experiences that their peers without congenital heart disease are facing, but they have a number of other challenges upon them. You know, the fears of their life, their prognosis, the challenges of taking medication, the appointments, feeling different from their peers. And so we certainly know that this mental health emergency is impacting our patients with congenital and acquired heart diseases as well. And so I want to take you through, just set the stage in terms of the patient populations that we take care of with regards to what we know about their mental health. So among our single ventricle patient population, we know that 65% of our patients with single ventricle heart disease will have a diagnosed mental health condition. 2 in every 3 will have a diagnosed mental health condition in their life. And what I think is really important about this statistic is this is diagnosed mental health condition. So this is not just the kids with, you know, subclinical levels of depression and anxiety that most certainly impact their ability to take medications, their ability to do well in school, their ability to sleep at night. So 2 in every 3 with a diagnosed condition. Among this patient population, they have a 5 times increased risk of an anxiety disorder compared to their peers, and a 6 times increased risk of ADHD. We know that people with ADHD have more difficulties in school, can struggle with future careers, and so there are continuous impacts of kind of these mental health comorbidities for our patients with single ventricle heart disease. Among our heart failure or heart transplant population, this was a study done looking at young people supported on VAD. And you can see here 40% of patients ages 8 and older had a current psychiatric diagnosis. When you collapse this group to just looking at the adolescent age patient population, this increases even more. Among some research that we did with adolescents with heart failure, we found that our patients had a psychosocial quality of life below the cutoff, and actually poorer quality of life when compared to other children with chronic conditions. So if we looked at our young people with heart failure and we compared to them to young people with cancer, for example, the psychosocial quality of life of our patients with heart failure was actually lower than those living with pediatric cancer. We can talk about maybe some of the reasons why that may be. And then for those that go on to receive heart transplant, you know, those stressors often persist for a number of patients. So 1 in every 3 children living with heart transplant continue to report high psychosocial stress well beyond the immediate post-transplant period. So this is actually reporting on data of patients who were on average about 6 years post-transplant. Less is known about our patients with ICD and arrhythmia conditions. This is actually a group where we have not done a lot of mental health focused research, but among a few single center studies where they've done this work, about 12%, or 1 in every 10 of our patients with ICD have a diagnosis of PTSD. So certainly the patients I take care of with ICD, there's a lot of trauma from shock or, you know, past arrest experiences. And so this group tends to carry a bit more traumatic responses. They also report lower quality of life. And about 1 in every 3 have a mental health concern, even, you know, 2 to 4 years post that ICD placement. And unfortunately, and I think really important for us to still talk about, we know that racial disparities very much exist for our patients with congenital heart disease as it relates to their mental health condition. So this is really great work by Vincent Gonzalez and Kayla Lopez out of Texas Children's Hospital, where they found that patients have a 5 to 7 times increased risk of a mental health condition compared to their peers if they have congenital heart disease. But more importantly, there is an increasing probability of mental health diagnoses as the child neighborhood poverty index increases. And Black and Hispanic teens with congenital heart disease are nearly half as likely to receive a diagnosis or treatment for their mental health condition when compared to their white peers with CHD. So I think this is really important for us to see and acknowledge. And again, as you look at this compared to other chronic illness populations, our group is the group that has increasing rates of mental health concerns as neighborhood poverty increases. So across other patient populations, perhaps they're doing a better job of kind of identifying the need and addressing the concern. So we also know that the psychosocial impact extends far beyond our patients themselves and into their family system. So 30% of parents of a child with a critical congenital heart disease have symptoms consistent with a PTSD diagnosis. And certainly, I think you probably all see this on the floors and in your clinics. Among parents, and this is primarily research that's been done in mothers, but mothers have a 25 to 50% risk of a diagnosis for depression or anxiety. And again, this is diagnosable conditions, which I can't speak to enough because, in my own clinics, for me to actually diagnose depression or anxiety, it's quite a fair amount of impairment. And so there are many, many subclinical symptoms that are not represented in these very significant prevalence rates. And we are learning more about this specific to congenital heart disease, but certainly in the broader child mental health, child psychology literature, we know that parent mental health impacts child mental health, but also impacts child outcomes generally, right? So, childhood education, childhood development. This is a fascinating study by one of my former fellows, now faculty, Catherine Dusing, and she was looking at parent mental health in our single ventricle patient population at Michigan, and found that parents who had a past history of an adverse childhood experience, so the parent themselves reported that they had experienced, a trauma, a loss, et cetera, something very significant during their childhood. Their child with single ventricle heart disease experienced more hospitalizations and had longer length of stay. So unaddressed or persisting parent mental health directly associated with child cardiac outcomes in our own patient population at Michigan. And so there's much more work being done on this. And I think it's a really important direction for our field where they're looking at parent mental health during the fetal period, et cetera, and its impact on our patients. Less known about siblings, but I think we all very much see the impact on our siblings, the patients that we care for as well. Some research suggests anywhere between 14 to 40% of siblings of a child with congenital heart disease experience their own psychosocial risk. Anywhere between 10 and 20% of the U.S. general population of children have a mental health condition, kind of pending the diagnosis. So across some of these studies, this falls within the normative range, but certainly in studies we see up to 40%, which would be kind of more than is typical. In an interesting study, I'm looking at siblings of children across chronic conditions. This systematic review had found that siblings of children with congenital heart disease actually had higher psychosocial morbidity than siblings of children with cancer, cystic fibrosis, and diabetes. If you haven't read it, I think this is a really great article by Michelle Stelzer. She's a cardiac MP at Lurie Children's Hospital. And she lived with a brother with congenital heart disease. He died in his young adulthood, but she speaks about the impact on her as a sibling of someone with congenital heart disease. And it's a beautiful kind of firsthand perspective of both the challenges of that, but also what she grew and learned from within that experience for her. Then I think it's really striking and important for us to acknowledge the financial impact of congenital heart disease on our patients and families. So this is a recent report done by the Additional Ventures Group, found that the average annual cost of critical congenital heart disease is nearly $50,000 per patient. With 50% annually, with 50% of that paid out of pocket by patients and families. When you're thinking about time off work, travel to and from the hospital, just the amount of door dashing you do, right? When you're sleeping at bedside and you're not getting the trays, et cetera. And the average lifetime financial burden of critical congenital heart disease is about $2.1 million per patient. So the financial impact adds additional psychosocial strain, stressors, depression, anxiety, sibling impact on the entire family system when we think about the cost of this. And actually, this is data from the ACTION Advanced Cardiac Improving Outcomes Network, which is the heart failure VAD specific learning network. And we were collecting patient-reported outcomes from patients supported on VAD. And what you can see here is that in the first 30 days, which is the top graph, post-implant, this is looking at a parent report of their own stress. You can see that, balancing parenting and caregiver demands was high for parents. Their own sadness was high, and their worry, of course, at the end, very high. And you all might imagine, now they've been supported on VAD for over 30 days. They're becoming quite stable. Risk of that high risk of stroke in the first 30 days has passed, and maybe their families are doing better. But in fact, the opposite happened. They actually reported more stress that the longer they were supported on device. So you can see sibling distress higher, financial strain and stress higher, family conflict higher, balancing caregiver demands higher, everything across the board. The parents reported that it become considerably more stressful for them the longer their child was on device. This was a variety of devices, so both kids on Berlin as well as HeartMate 3, probably some HeartMate 2s in this group, but so not kind of separated by device based upon the sample size. It's very possible that HeartMate 3s might look different than Berlin's, but I think just important to acknowledge that this stress and strain on family systems extends well beyond that acute illness period, which is where I think we tend to think about providing the most support, and that need for kind of longitudinal support is very pressing. And other, I think, important psychosocial considerations for us to be thinking about is, certainly across some of our patient groups, I do most of my clinical work in heart transplant, where we have very high rates of non-adherence, anywhere between 50 to 65% of adolescents with a solid organ transplant do not take their medication as prescribed. This is hugely impactful and contributes to about 1/3 of graft loss in adolescents and young adults with solid organ transplant. We also know that among our patients with congenital heart disease, a subset have neurodevelopmental impact from their early surgeries, ECMO runs, bypass, et cetera. As we're taking care of many more young adults into adulthood, we are also recognizing that there are gaps in care, with a number of patients being lost to follow-up when they transition from their pediatric care team to their adult care team. And then, of course, as I'll talk a little bit more about today during the noon talk, there's high risk of mortality and morbidity among our patients. So they're also, thinking about advanced care planning and end of life, their prognosis, and this can impact their sleep, contributes to pain and worry. So there are so many psychosocial considerations, both when we're thinking about kind of diagnostically and mental health for our patients and their families, but also other areas that impact their heart care and how you're caring for them in the hospital and in your clinics. So with that, I think, over the last couple of years, we have seen a tremendous call to action. I think that, when I first started in this space, I found that cardiology groups were certainly agreed mental health was important, but we were far behind other pediatric illness groups like pediatric cancer, for example, or cystic fibrosis, where they had been really working on and thinking about mental health and psychosocial care for a decade or so earlier. Now, this is featured at nearly every conference. There are visiting professorships at heart centers where we're talking about mental health. And I think we were at a really different place, a really important place in our field, where everyone is coming together to say, we're doing a great job with surgical advancements and technological advancements and improving the quality of the care of our patients in our ICUs, but we really need to do more to support our patients and their families from a psychosocial perspective. And we have some data, I think now, as we're talking with leadership, as we're talking with our institutions about why this really matters, beyond kind of the patient stories that we all know and feel very deeply. So in a large single center study of adults with congenital heart disease, this was actually out of the Boston Biobank study, a diagnosis of depression was associated with inflammation biomarkers and heart failure, as well as a 3 times increased risk of all-cause mortality. And this was after they controlled for age, sex, CHD complexity, presence of arrhythmia, systolic function, and QT interval. So they controlled for a number of the cardiac factors and found simply a diagnosis of depression, 3 times increased risk of mortality. We've talked a bit about our pediatric heart transplant recipients, but for our patients with a pre-transplant diagnosis of depression, it was independently associated with graft loss during their post-transplant period, and anxiety and depression were both associated with higher rates of readmission. So again, when you're talking with hospital leadership, et cetera, these are survival outcomes, these are length of stay, hospital bed outcomes that are really, really important when we're kind of thinking about access and care, but really associating mental health with these cardiac outcomes for our patients. And we now have scientific statements across the American Heart Association and many others that say mental health is critically important to cardiac health. So, and this adult statement, it's circulation, 2021, is a fabulous scientific statement. If you have not read it yet, I really encourage you to, where it is this tremendous systematic review looking at how mental health diagnoses are associated with mortality, heart failure, et cetera. We do not have as much robust data in pediatrics yet, but we're getting there. So I think a really important piece for advocating for this for our patients and families. As I mentioned, the call to action, this is a JACC paper from the NIH, which was really saying Pediatric Heart Network and a number of NIH stakeholders that highlights mental health as really the next frontier in pediatric heart disease. This is an AHA-specific scientific statement for congenital heart disease that it can be used to advocate for these services and programs within our own hospitals, saying that we really need to improve psychological outcomes and bring about interventions for our patients. With that in mind, I think social determinants of health very much interplay with this, and we now have the AHA scientific statement specific to that. And the CNOT group, the Cardiac Neurodevelopmental Outcomes Collaborative, has been bringing forward a number of scientific statement papers related to neurodevelopmental and psychosocial interventions for our patients as well. And these are just a few. The International Society for Heart and Lung Transplantation, there are so many that have come out in the last 5 years, really, saying it's really time for us to start to address this. And so we have the scientific statements, we have the need. I think we all recognize and agree that it's important, But unfortunately, I think bringing the clinical intervention, bringing the initiatives to the bedside is a challenge and has been slow. I think, you know, we've now kind of got the energy and the excitement and the shared agreement that it's important. But how do we actually move forward to bring change for our patients and families? And so that's what I hope we can spend kind of the rest of our time talking about. Some gaps in care. So we know that our patients are feeling this as well. They report feeling under-supported with regard to their mental health and psychosocial care. So this is a Pediatric Heart Network study. It was led by Amanda McCormick through a Pediatric Heart Network Scholar Grant, where she surveyed young people and their parents with single ventricle heart disease across 4 centers, so a diverse group of heart centers. You can see here over half of parents of children with single ventricle heart disease were concerned about their child's mental health. About half of parents of children with single ventricle heart disease desired more supports for their child. Among some single center studies, as well as a really large international study we did with over 1,200 participants, young people with heart disease themselves desire more cardiac specific mental health support. So anywhere between 30 to 80% of young people with congenital heart disease said, yes, please, I need more heart specific mental health support. I think it's really important here to acknowledge what they specifically were saying yes to. They were not saying they needed more mental health support generally. They were saying they needed more cardiac specific mental health support, which I think is really important. I find often, you know, a pediatrician, someone in the community, the school gives a referral to our patients, you know, for their depression, for their anxiety, et cetera. Sometimes they can get connected with someone in the community and that's a really good fit. But many times they feel like they just don't understand. They've never taken care of someone with half a heart before. And, you know, they're trying to kind of use certain strategies to reduce their angst related to their upcoming surgery, but not understanding that or that disconnect for them is a gap. And so they're really feeling like they need services that are integrated and embedded and a part of their heart-specific care, which I think is important, you know, for us in this room to be thinking about. Despite the high prevalence, despite the impact on cardiac outcomes, and despite the fact that our patients and families say that they want this, they desire it, there have only been 4 adolescent-directed mental health interventions in congenital heart disease. Only 4. This was through a systematic review looking at mental health interventions in congenital heart disease back in 2019. And aside from the one we're about to launch through the Pediatric Heart Network, I'm not familiar of any others that have happened since then. So again, I think when we compare this to other illness groups, like childhood cancer, for example, childhood diabetes, there are considerably more interventions that have been done in these spaces. So we are really, really, you know, far behind in addressing these gaps in care for our patients. So what do we do about it? Now we're going to switch gears and I think hopefully get everyone excited about some things and ideas practically that you can bring to your own work and to your advocacy, I think most importantly. So as Erin mentioned, in 2020, we launched the MCOPE program within the University of Michigan Congenital Heart Center. So this is a bit of our timeline. I first started at the University of Michigan in 2015. And at the time, I was hired to be our heart transplant and kidney transplant psychologist. In 2015, our heart center did not have any cardiac-specific psychology services. We did have our cardiac neurodevelopmental program. So we were, you know, engaged in providing neurodevelopmental services, but we did not have any mental health services for our patients prior to 2015. So if they needed a mental health referral, it was kind of, you know, sent into the various places we all send them, right? We tell them to talk to their pediatrician, we send a referral to the general hospital psychology service, et cetera. So in 2015, we started to build psychology services within our heart transplant program specifically. And from 2015 and 2020, that was really our focus, my focus personally. And we built, I think, a pretty robust psychosocial program. I was embedded within the transplant clinic. I saw patients as they came for their multidisciplinary transplant visits. I also saw them on their inpatient, during inpatient stays. So there was this continuity of care for them across their transplant care. And I met all of them when they first came to meet the transplant team. And it was not for this evaluation. I hate that we call it a psychosocial evaluation, but it was, as I would tell families, you know, this is really a consultation because we know and expect this to be stressful. We know and expect there to be times where this is really hard for you. And so we want you to have access to mental health services from the very start of this experience. And I now have far too many patients that I've been following for 10 plus years. As part of that service. You can see I highlight some of the research that we had going on around the same time, and I'm going to talk a little bit more about that at noon today, so I'll focus mostly on kind of the clinical program development. But essentially what happened was over that 2015 to 2020 time period, the rest of our heart center, the rest of our cardiologists were saying, well, this is great that you guys are doing this in transplant, but what about our patients, you know, with single ventricle heart disease who are not yet needing transplant? What about our patients with ICDs and arrhythmias? What about our patients with pulmonary hypertension? Like they need these services too. And so in 2020, we officially launched the MCOPE program. And really all that meant was we established mental health as a leadership role within our heart center. So what was happening was we had social workers, we had child life specialists, you know, we had part of psychology, we had our partners in the neurodevelopmental clinic, but we had all of these mental health supports that were kind of, you know, piecemealed. Some were hospital provided, some were Department of Peds provided, some were in the Department of Psychiatry, you know, in another place. And we also had, respectfully, cardiologists making the decisions at the top level about what these supports should look like. And so all that we did in 2020 was we gave it a name, we made a mission statement, and I started to join officially our heart center subspecialty director meetings. That was really it. That was really the start of it. We brought together pretty much everyone across our cardiac care settings, outpatient clinics, inpatient, that were a psychosocial provider that interacted or touched our patients in any way, and we formed a group. We kind of brought everyone together and said, let's talk about what we're doing, let's talk about where we want to go. And that was really the start of it. There was no funds allocated initially. There was no, you know, people always say like, oh, if we only had the resources. We had no resources at the time. This was really just coming together as a heart center to say, we want to give this a pillar. We want this to have its own, just like we have the fetal program and the transplant program, we want to have a mental health program in our heart center. So that's what we did in 2020. We did a needs assessment. We went around, we met with every program leader, we met with nursing on the floors, we met with our social workers, we talked with everyone. We said, what are the strengths of, you know, kind of what we're already doing? What are our areas of opportunity? What are our highest need groups where, you know, we're not going to be able to open up the referral doors to everyone, but where should we start? Where should we really start to kind of grow our program? And that needs assessment then really informed kind of our next steps. In 2021, so in 2020, it was still just me. But in 2021, I was able to advocate for some support at our heart center level for a psychology fellowship. Psychology fellows are, unfortunately for us, but fortunately for others, very affordable. It does not take a lot of funds to support a fellowship. And in the state of Michigan, I'm not sure how it is here in Oregon, our fellows actually operate as limited licensed psychology and mental health providers. So they can actually see patients independently of me, their own patient caseload, and I sign their notes, I supervise their case, but they can really operate quite independently when it comes to providing, mental health services. So we got support for a full-time dedicated 1.0 cardiac psychology fellow. And this greatly expanded access to services. So we were able to recruit a really amazing fellow. And our fellowship program has been hugely successful. Our fellows are always billing over 100% of their RVU targets. And that allowed us to start to first expand to those groups of highest need. So single ventricle clinic, fetal, were some of the groups where we first started to kind of increase access to services. Then this fellow, over 2 years, matriculated into our first additional cardiac psychology faculty hire. So then we had an N of 2 of us. Dr. Dusine focused largely on serving the needs of our early childhood patient population, doing a lot of parenting support in our single ventricle clinic. So then in 2023, knowing that model worked very well, we posted and hired our second cardiac psychology fellow. This one focused on the opposite side of the spectrum and really supporting transition in adult congenital. And fortunately, she just accepted a position to stay on with us as our third full-time dedicated cardiac psychology faculty person. So that was really how we grew in those spaces. I will say, when we started the program in 2020, we already had 5 social workers in our heart center. So we actually were really well resourced from a social work perspective. We also had 4 child life specialists, and we had a full-time dedicated education specialist in our heart center, so a school teacher. So I'm focusing on the psychology piece of growth because that was the area where we were most limited from a resource perspective. But our social workers were in different departments. They inpatient and outpatient were not, always communicating. So it was kind of really bringing together this whole team under the MCOPE program umbrella that allowed us to, I think, kind of really start to address needs. Excitingly, starting in the fall, we are also going to have a perinatal psychiatrist joining our team. She's actually an adult psychiatry hire, but is going to have a half-day clinic a week to serve the needs of our parents, specifically from our fetal group. So we're really excited about that. So this is a brochure from our MCOPE team, really letting our parents and families and patients know about all of the groups of people we have working in our heart center that can support their psychosocial needs, and specifically what we can connect them with. You'll see, in addition to our own program, we also highlight a number of the resources that are available throughout the University of Michigan and the institution. So really trying to connect them with resources, even things that we may not be able to offer or that we're offering kind of internally within our program. So why integrate? Why advocate for having these mental health services, within your clinics? So this is a psychosocial team benchmarking and pediatric heart center study we did. This is a couple of years old now, but we had 14 heart centers that responded. And some of these were smaller volume, medium volume, and we had a few that were higher volume centers. You can see here that about 70% of heart centers, so again, of the 14 heart centers, had transplant psychology embedded within their clinic. Single ventricle was the group that then had the next kind of highest level of embedded services, followed by EP. I would say that when we did our own internal needs assessment, this is pretty similar to what we were finding our cardiologists reporting the areas where they felt like they had the most need in terms of kind of having embedded services. But this data has been really helpful for some centers that were trying to, for example, advocate for a transplant psychologist or a single ventricle psychologist, because they were able to go to their leadership and say, look, at 70% of other children's hospitals have this within their heart center. We don't, we really need this to kind of grow. So this has been helpful. We've actually been internally keeping this updated, and I'm happy to share the data in a more detailed view for anyone needing it. But I think more importantly, this is why we integrate. So when a young person goes to their PCP or their school counselor and a mental health referral is given, and they say, you know, we're really concerned about their mood, we're concerned about their depression, anxiety, we really want them to see a counselor. Anywhere between 1 and 10% of those patients actually connect with a mental health provider. The rate of follow-up and connecting with a mental health provider in the general community for young people is incredibly low. And there are a lot of reasons for that. One is access, there's not enough. 2 is insurance barriers and cost, unfortunately. Some people do not have mental health coverage. And the out-of-pocket expense of $150 to $300 a week is a lot. Time, stigma, although quite frankly, I think that one is no longer, it's actually quite cool these days to have a mental health provider and take care of your mental health. So that one I think is fortunately on the decline, but for some, it could still be a barrier. This is the number of new outpatient referrals to our psychology team in a year's time. So I really highlight new because, like I said, you know, I have many patients that we have been following for years. So these were just new individual patients to us. But what I think is really important is the percent that we're seeing for at least 1 or more psychology visits. So among our general cardiology referrals, so this included our fetal and interstage patient population, of those referred, 72% were seen for at least 1 visit, compared to the rates of the community, which were 1 to 10%. Of our heart failure transplant, 82% were seen for at least 1 visit. The 3 patients who were not seen, 2 didn't have portal. They didn't have their video visit set up. And 1 didn't have insurance coverage. So it otherwise would have been 100%. And among our transition and adult congenital group, again, this is the group 2 in every 3 struggle to even make it to their adult cardiology appointments. But among our transition adult congenital group, 2/3 made it to their first psychology visit. And so people might say, like, why? Well, I think it's really clear why. They come to their cardiologist. Their cardiologist says, I'm concerned about your mental health, or I really think this service would be helpful for you. I want you to see my friend, my colleague, you know, Dr. Husno. She's a psychologist. She works right in a heart center. And that just feels, it's like referring them to go, you know, get their echo done. It's like referring them to go see the surgeon that you work with. It feels like it's part of their cardiac care. You are able to speak to who this person is as part of your team, as one of your partners. And I think for the patients and families, it's really speaking to one of their unmet needs. So we are starting to kind of integrate more fully into some other specific groups. So currently, I would say we're very embedded, kind of part of the multidisciplinary care team for transplant, single ventricle, and transition adult congenital heart disease. We take referrals heart center wide from all of our groups, but those are the groups that we kind of sit with and see those patients as part of clinic. But the next group that we're expanding to is our interstage and home monitoring group. So we're really excited about this. This is through a philanthropic gift, which we'll talk a little bit more about. We're going to be meeting, psychology is going to be meeting every family prior to their discharge following their stage 1 surgery. We're going to do a psychosocial screen for the parent, but also for the family system, and then develop a mental health follow-up plan for that family system prior to their discharge home. We believe strongly that through, in addition to our, excellent home monitoring services and the incredible work of our cardiac NPs and nurses who are following this really, fragile patient group at home, we believe that addressing the family stress for this patient group is going to reduce hospitalizations and healthcare utilization. And so I believe it so firmly that, I told our hospital CEO, and we're going to be tracking this, and they, of course, are really interested. So that's kind of the next adventure. That said, when we don't have access to services, when you don't have, what did we do in those early years when we didn't have a team of 3 psychologists and a perinatal psychiatrist? What we were trying to do is just share resources. There are so many great supports that already exist through a number of organizations. There are peer connection groups, there are caregiver support groups. What we were finding is that some of our patients and families knew about them, often the ones who were really highly educated, very engaged, but many of our patients and families had no idea. Ollie's Branch is a wonderful nonprofit organization that actually provides 8 free therapy sessions to people with congenital heart disease as well as their caregivers. So if this isn't an organization that you've explored yet here, I really encourage you to explore. They partner with cardiology groups and heart centers, and they may already be very operable here in Oregon. We use them for our Ohio patients. Many of our patients living in Ohio may not have insurance coverage for our services in the state of Michigan, and so I'll often refer and connect them with an Ollie's Branch therapist. And what's really amazing about this group is they recruit kind of community providers to their network of therapists, but they provide training to them in caring for young people with congenital heart disease. So even though it's, local community providers, they give them some information on, how do you support young people with these diseases and conditions, and then provide 8 free therapy sessions as well. This is Caregiver Connect, which is through Transplant Families. It's a monthly social work-led caregiver support group. And so, really spending time, among your group to say, where are we referring our patients to? What are the societies and organizations that have really good resources here locally and nationally? And starting to develop those resources and make sure we're really sharing them with our patients and families. Training. So I always joke with the cardiologists that I work with that, when I'm seeing a patient and I find out they're not sleeping well, I'll ask them a couple of questions. And one of my questions is, do you need multiple pillows to prop yourself up when you sleep? And if they say yes, I know that they need to go see their cardiologist, right? So I've learned that I can ask 2 more questions about sleep. And oftentimes, the heart failure doctors always joke. They're like, well, we're seeing them back in 3 months, but Melissa will be monitoring their symptoms weekly, which is true. But I don't have to know how to treat their heart failure. I don't even know, all I need to know is to ask that one question, and it signals need for additional services. And I think the same should be true for cardiology clinicians. You don't need to know how to have to treat serious depression. You don't even know how to need to do a safety plan in terms of suicidality. But if you can ask a couple of additional questions, you can identify the patients and families in your clinic that really need services and be the one to help trigger and get them to where they need to go. And so, again, my colleague, Dr. Mandy McCormick, she is one of our associate directors of our Pediatric Cardiology Fellowship Program. And what she developed was a mental health curriculum specifically for our pediatric cardiology fellows. Dr. McCormick is sharing this curriculum. So if it's something you are interested in bringing to your group, it's offered to our fellows, but our heart center, MPs, nurses, cardiologists come as well. We're in our 4th or 5th year now of doing this program, but essentially it's 3 to 5 talks, very focused on, how do you address or ask about mental health concerns in your clinic? What do you do when you identify them? Kind of some of those barriers for oh, I don't want to ask that question because then my clinic is 20 minutes longer, or I don't know what to do if they tell me they're depressed. And so this curriculum is designed to be a very kind of practical, how do we address mental health within our clinic? And Dr. McCormick has studied the curriculum. There's actually a paper now that's been published on it, which found, at the start of our curriculum, our pediatric cardiology fellows were very uncomfortable asking about mental health, addressing mental health in their clinics. By the end of the curriculum, they felt considerably more competent in terms of addressing mental health. And I think we all, it's important to say and know when 2 of every 3 of our patients with single ventricle heart disease have a diagnosable mental health condition, I do think it is now upon us, upon you, as pediatric cardiology clinicians to ask these questions in your clinics. Many of these patients are not seeing their PCPs as often as they are seeing you. And so while these, are kind of questions or domains that 10 years ago we left to the PCPs, I think times have changed now, and it really is upon subspecialty providers to be asking about these questions and connecting patients and families. So how do you do it? There's some practical screening tools. The GAD-2 is a 2-item screener for generalized anxiety disorder. It can be embedded right into your EMR. The PHQ-2 is a depression screener, or you can just ask. And so this is really what I teach our cardiology fellows. I know a lot of patients with your same heart disease. Many tell me that they feel sad, sad about their heart, about their friends. Many tell me that this is stressful. When was the last time you felt like this? On a scale of 1 to 10, 10 being the happiest you are, 1 being the saddest you are, what are you today? So it can be a really easy, less than 3-minute thing to integrate into your clinic flow. What do we do in real time if they acknowledge that they have concerns or challenges or problems? This is literally a slide from the fellows talk that I give. You can immediately talk with them about behavioral activation. Behavioral activation is one of the most effective interventions for depression. So you can say, I sometimes feel sad too. Sometimes I feel like I don't want to go do things. What is something fun you can commit to doing this week? What is something, you can do, even though you don't want to do it, it's important to your heart that we think about this. So, in addition to changing their meds or whatever else you're going to put on their after visit summary, you may say you're going to go on, outside and play a game with your brother. I also have a ton of apps on my phone. These are a couple kind of pediatric specific ones: MindShift, Smiling Mind, Mango Health. There are even more now. There are some super cool AI ones now that exist. But I think it's so powerful when you're in your clinic and you identify a mental health concern, when you pull up on your phone and say, this is a gratitude journal that I sometimes use, or this is a cognitive behavioral therapy journal that I sometimes use. You show it to your patient in real time and you encourage them to download it and do the same. You may not be able to get them connected immediately with a therapist, but you can start the process of intervening right in your clinic. And then lastly, I'm just watching my time. My watch is about to die. Someone know the time? Okay. And then, I think what's been really exciting since we launched the MCOPE program, so since we actually gave it a home and an identity in our heart center, what has started to happen is all of the amazing people in our heart center who have incredible ideas about how to improve mental health, psychosocial care for our patients and families, they now know where to go to talk about an idea. Like before, it was really intimidating to go to our surgical director and say, hey, I have this idea for something I want to do. But now they know that we have a leader in our heart center that can help us think about this and help us implement this. And so what has happened is we have these incredible things that are coming, in a very low cost way to improve some of these really important aspects of care for our patients and families. So this is the iEcho program. We just launched this a year ago. This program came from our cardiac MP and our sonographers. There was a patient who had developmental delay, and the family was sharing, that echoes are just terrible. When they have an echo, that week, their child is really stressed. They can't go to school. They dread echoes. And she said, can I just take a transducer home? Can I take an echo probe home so that we can practice doing echoes for the week? And one of our sonographers said, oh, I have a 3D printer. I'll 3D print an echo probe for them. And so we did. He 3D printed, it cost 3 cents per echo transducer to 3D print an echo probe. And the rest of the team said, we have, there is at least a few patients a day that are coming in who need sedation for their echo, who take a really long time to get through their echo. We should make this into more of a formalized program. We got an internal grant through our hospital, our adult heart center actually, $5,000. We bought our own 3D printer. So now we have a heart center 3D printer to 3D print echo probes. We developed a game board, which is essentially systematic desensitization. So our child life specialists helped us with this, and kind of the steps we would walk through to walk a young child through, or adolescent child through that. There's a social story that's been created with it, pictures of what it looks like to get their echo, et cetera. And now we're studying it, because that's what I do, so that we then have the data to kind of support the program. But we've had 5 patients who've went home so far with these. This is like just launched. 2 have required sedated echoes their entire life. 2 who had required sedated echoes their entire life had their first unsedated echoes ever. So what's been so exciting is like this is really led by sonography, by child life, and it is hugely impactful. This is another one that is starting this coming year. We're partnering with our hospital music therapist for $5,000. We're funding our own music therapy intern for the Heart Center. And this music therapy intern is going to be developing inpatient music therapy groups for our infants and preschoolers who are on the unit for a really long time, who are not in precautions. They can go to these kind of preschool-like music therapy groups to improve neurodevelopment, but we also think it's going to really improve parental coping to have this for their child. In addition, they're going to be doing some voice lung capacity work for patients after surgery. We're studying it for $5,000 a year, and I think I expect it's going to be really, really successful. But what happened was, I don't think these music therapists would have ever been able to come to us with this idea to kind of bring this program without knowing who to go to. And I'll say this because I'm going to talk about the We Beat program during the noon talk, which is the first ever randomized clinical trial of a mental health intervention for patients. So in summary, I think it's really important that mental health and psychosocial leaders have a seat at the table. I think that there should be someone within every heart center that is an identified leader in these spaces. I think philanthropic partnerships are key. I will tell you, once we established the MCOPE program and we made it known that this was a program in our heart center, the amount of philanthropic dollars we have been able to bring in has been incredible. Many patients and families want to give specifically to this type of support. And even small gifts, $5,000 from a funeral, for example, can really bring big impact. So once you have the program established, the philanthropic partnerships come, which has allowed us to fund our adult congenital transition psychologist, for example. 25% of her salary is being funded by philanthropy. So that's how we've been able to do that. And then, as we've talked about, it brings tremendous value. It's important to U.S. News, World and Report. It improved cardiac outcomes, but most importantly, it's desired by our patients and families. It.
That was fantastic. Who needs a towel after drinking out of that fire hose? No, that was a truly inspiring talk. I came into this lecture having some opaque idea that we needed more for the psychosocial challenges for our patients, and now that's much more concrete. So thank you very much for this wealth of information, but also delivering it in such a structured way that was really easy to follow and be inspired by. I do wonder what else could you have left for the noon talk, but we're about to learn that. So I make an executive decision here to spend a little bit more time for some questions and discussions. So Ashok's our lead surgeon, and
wondering if we should send our kids home with some scalpels so they can practice, Surgery without anesthesia. Yeah, exactly. Yeah, all right.
I do want to make EKG leads. My son had to get a cardiac workup done. He's fine. So I took the echo probe home. We blew through the echo, but he lost his mind during the EKG, and I was sweating bullets because I was like in the clinic. My child was refusing the EKG. So that's my next 3D printed.
So when we look at post-transplant kids, you talked about the high rate of medication non-compliance.
Mm-hmm.
Do you see a difference between kids that have congenital heart disease and kids that don't?
Oh, good question. That has not really been well studied. It should be. I would say I personally do not see as much of a difference. I just see the challenge of adolescence. I think that I probably, if I'm thinking about my non-adherence referrals, probably more have cardiomyopathy than congenital heart disease, but there are many still of my patients with congenital heart disease who still struggle to take their medications as prescribed.
Today, we are still talking about, our congenital heart disease kids have neurodevelopmental issues because of bypass and ECMO. And I thought we were past all that in the 1980s. I thought we were thinking congenital heart disease, neurodevelopmental issues had to do more with their white matter development, which is also congenital in nature or because of the way the blood circulates in the brain during all through fetal life. Do we still believe it's from bypass and what we do in the operating room? There's also, I thought, some data that correlates mental health issues with length of hospital stay, length of ICU stay, overall sedation, mechanical ventilation. So how do we parse out all these factors?
Yeah, I mean, so I'm far from I'm far from one of the brain neurodevelopmental experts. But from what I understand, it's all of the factors. It's still the brain development in utero, and trying to really understand that from a genetic and biological place. It is still the bypass runs and the ECMO. It's the hospitalization and the experience of being in the ICU and not having the same developmental experiences through infancy. From what I understand, it's still this very constellation of risk factors. And we're not to the point in terms of our predictability models and kind of precision medicine to truly understand what's impacting who, but they're starting to do that. The other PHN trial that's going to be funded is actually going to be looking at some of this. They're collecting cord blood, they're collecting plasma, they're doing fetal MRI and post delivery MRI to really try to risk stratify all of these neurodevelopmental impacts for these infants.
Thanks, Melissa. So as a fetal provider, one of the things that's always struck me is all the information that you presented for congenital heart disease and how it impacts the family, the siblings, and the patient themselves. How much of that do you think is important that we really get into detail sharing during our fetal visits? There was this whole thing, I don't know, 15 years ago where the stress and anxiety of even having a fetal diagnosis for the mom was really challenging. And there was some discussion about whether or not that was even worth that risk of having that stress for a mom during the fetal time. I'm not sure how much to share. I mean, we go through that, the impacts, but do you think sharing some of the numbers that are so profound has any role in our fetal counseling?
Yeah, it's a good question. I'm actually talking a little bit about that at noon in terms of fetal counseling. I think what my ideal would be, and I think what we're going to try to start to do with this CHAMPS program model is something that's very similar to kind of the transplant model, where every family is meeting with a psychosocial provider as part of that, where we can say, where we can speak specifically to that as patients and families want to. So when I meet families for transplant, I sometimes have the moms of a 3-month-old baby who wants to know everything. They want to know, are they going to have depression and anxiety when they're 15? How is this impacted? And then I have others that are just like, we are so overwhelmed by and we don't talk about it then. And I say, you're meeting me now, and we can continue to have these conversations when the time is right. I think that's what's important. Not having the information, but having the connection to the information when they're ready for it, is what I think is the important piece. I think that if we give them all of that information, it can be very overwhelming. So let's just provide them with the support and the connection to the information so that they can get it when ready. Does that make sense? Mm-hmm. In terms of their decision making about. Mm-hmm, mm-hmm, mm-hmm.
And that's where I struggle with
Yeah.
transplant.
Yeah, so some of these, the studies that said there's some studies I'm going to cite that I'll talk about today at noon. And it's small samples of parents, but there's research from parents saying, there's a fascinating study where they looked at fetal cardiologists. How important it is, do you think, to talk about these things? And then they asked parents, how important is it to talk about these things? And generally, what the literature suggests is that parents think it is more important to talk about the long-term things, neurodevelopment, mental health, transplant, et cetera, than cardiologists think it's important to talk about in the actual fetal counseling session. So the suggestion from parents that they do want to hear more about these long-term things, whereas I think we try to protect or not overwhelm some with all the information.
Thank you. It's a great talk. And I think in our world, and particularly this institution where we're preaching or we're hearing a lot about scarcity, it was nice to see some pathways of the how, which is great. And I really appreciate that. Because there's some adult cardiologists here and online, I wanted to switch topics just slightly to beta blockers, your experience. How would you suggest us? Do you see really an effect of beta blockers related to patients' mental health, number one, in sort of the grand scope of your practice and experience? And two, how do you mitigate that? How do we as cardiologists discuss that with our patients if we think that that's an important drug to be on for what they need?
In my practice, in our heart center, we have no concerns about, we have no concerns about them starting any mental health medication in terms of its cardiac impact. I mean, almost all of the cardiologists I work with will say, we can start anything, we'll monitor them from a cardiac perspective. And then vice versa, we should treat what we need to treat with their heart condition, and we will support them from a mental health perspective. So when it comes to the conversation around medications, where we provide the medication that's needed and we provide the intervention and follow up on the opposite side. But I have not had a patient not receive something for either reason. They needed it from a cardiac perspective, and there was concerns about, its impact on mental health, or it was a mental health intervention and they were concerned about QT prolongation, et cetera.
Hi, thank you again. This is such a great talk. So we run a summer camp for our kids with heart disease for the purpose of, mental health and activity. We also have monthly, lots of activities during the year. You said that the patients really look for support groups and things. What would be something that you could see would be useful with, the structure that we have already with our camp throughout the year to give kids that access, that support that they're looking for?
Yeah, great question. It's exciting to hear about your camp. I'd love to learn more. I'm curious what your experience, those of you who've gone to camp or run camp, I'm curious your experience. My experience has been, when I go to a summer camp or I lead a support group, that the kids are not talking about their heart disease at all. They may not even mention what their diagnosis is, but it's just being in a room or being in a place where they know people get it, where they don't feel like different, that in and of itself is the intervention. So what I think is often a misdemeanor is that the support groups that they're requesting or that they need is like, everyone come together and talk about your heart journey, when in fact, that's not really what they're looking for. It's just being in a place of others who get them. And so perhaps it's, as we'll talk about the We Beat program at noon, it's bringing in some general like resiliency building education or some coping skills education that we all can benefit from, you know, very podcasty style or in a really fun way, to provide them with skills for mental health and just supporting well-being, but not necessarily in this therapeutic way. Does that make sense? So I think that's a thing to bring to the support group need.
For coming, and I was taking notes as best I could. Part of my role is to help explain the why and get the funds to do program building. And so I wonder, first of all, I will reach out to you for some of your some of the work that you did to get the funding, right? And I'm wondering if you can explain, or if you had a few aha moments or pivotal moments with your leadership, with the people that hold the purse strings. Where do we focus? How do we make that? I'm not asking you to tell me how to do my job. I mean, a little bit, but I guess like what were the biggest impactful pieces of data or research that you used to make that statement?
Yeah. So I think the patient family needs assessments. So the data from the patients and families saying this is a huge need and unaddressed need for us. I am at an institution that is quite competitive, I think not just in football, but generally. And what was really important to them and my leadership, to our leader, was to say, this is what CHOP has. This is what Cincinnati, I'm sorry, I used it, it works. That rung for my leadership specifically. And you know, I think initially that's what got the program started, was that, you know, patient and family had need and there were other hospitals that were providing this and we weren't. I think that got the initial support. Then I think now what they've actually seen we've been able to do, et cetera, now it is everyone really truly is fully committed and invested in it. And that dollar and cents question is really different. It's, of course, we're going to support it. We're just going to figure out where we're going to get it from. So I think those were the things that were initially very helpful. I also had no effort initially from my heart center when we started this role. I wouldn't advocate for that. But, you know, it was really just the heart center coming around and saying, you know, we're going to invite a psychologist to sit in on our leadership meetings and help us think about our missions and values and goals and who talks to philanthropic donors. You know, do we really want to go after a hybrid OR, or do we want to, you know, fund $50,000 for this program? And so just then, now I get 10% effort is what I get for my leadership role, which then allows me to consult on like the music therapy program and all of that. So there's a small chunk of money, 10%, which has allowed us to really expand reach. So patient family data, other heart center data, and an initial small amount of support for the person leading the effort.
Also incredibly grateful for that wonderful presentation. So thank you. And I'm looking forward to chatting with you a little bit more later. I have a question from the ICU perspective. I'm one of the intensivists. And we know that how parents experience acute decompensation or events in the ICU and how they're able to kind of frame that experience, especially in the face of ongoing trauma, as they may be in the intensive care unit with additional events, can impact their ability to have that resilience and support their children in the future. So I'm just curious about what your model is for providing resources, kind of that in intense acute phase, and how then that works into your outpatient model.
Yeah, good question. So I think inpatient, beyond transplant, where I will see every patient, upon admission essentially, because it's a targeted group that is like easy to track and follow. Our inpatient model is otherwise as consulted. So our social workers see every inpatient at least once a week. We have 2 fully dedicated inpatient social workers. So they will see everyone in the ICU and general floor at least once a week as part of their care. But psychology and some of our other psychosocial support services are on a consult basis only. So I will admit, I don't think we're as preventative or promotive. Oftentimes when we're getting consulted in the ICU, there is already like a major stressor, a major, we just don't have the bandwidth. I mean, even with 3 full-time dedicated psychologists, we don't have the bandwidth, I think, to serve the inpatient unit as we would want to. So social work will refer to us, the intensivist will refer to us, but it's really as they identify the need.
We are at time, unfortunately, but we'll have lots of opportunities to continue the conversation. I just want to wrap it up with perhaps 3 take-home messages from your talk that I try to remember. One is it's a scalable approach that, it's okay to start small, use something that you've built over a decade as a vision to work towards, but start, at an achievable level. 2, use the existing resources that are out there or that might be available at our institution. And 3, accompany the whole thing with an academic approach, using metrics of success and also recognizing that we do this in an academic environment with research as you're the best example. As we wrap this up, I really, really want to thank you again for gracing us with your visit today, for giving us insightful lectures and taking the trip. I would also like to give a special thanks to Erin Magiargo, who's championing this visit and was instrumental in putting together the itinerary together with you. And of course, our Hannah, who's behind the logistics of most things that we do, including this visit. So a few more meetings for you, many more meetings for you. We're keeping you really busy. I'm really sorry, but I'm not. And we'll see you all at noon for the pediatric grand rounds. Thank you very much.
I didn't think it would